Good morning, everyone, and welcome to Global Neurosciences Institute Grand Rounds. I'm not Dr. Rami, as you can all see. Dr. Rami's off this week, and actually it's more than appropriate that I will be introducing our speaker this morning, our very own Dr. Ken Liebman. Ken and I have worked together for well over 2 decades. Dr. Liebman is, as everyone knows, knows our group and knows him, is a very experienced, comprehensively trained vascular neurosurgeon. But what a lot of people don't know is he's also a very accomplished skull-based neurosurgeon, and trained at Jefferson at the time with one of the international leaders in skull-based surgery, Dr. Bill Buckheit, and very accomplished in acoustic neuroma surgery. And from there, when he began his training in endovascular, that led into minimally invasive techniques. And Dr. Liebman is actually, I would say, in the country, but certainly in the mid-Atlantic, is very well known and has a national referral basis for facial pain, not just trigeminal neuralgia, but all facets of facial pain. And much like comprehensive for vascular, whether it's a tumor on the nerve, whether it's just a pain syndrome, he is incredible. I send all of my patients to him for this. He is, again, very well known for this. And this is, I think, a really appropriate topic because there's a lot of misconceptions about facial pain in general, but particularly trigeminal neuralgia. And many people don't know the different treatment options, which there are many, from surgery to injections to even radiosurgery. So with that, it is my pleasure and honor to introduce Dr. Kenneth Liebman.
So thank you so much, Dr. Vez, for that wonderful introduction. And as Errol mentioned, I'm going to talk about trigeminal neuralgia, which is a form of facial pain. And I think most people do understand that concept. So I'd like to start off first by reviewing the basic anatomy of the fifth cranial nerve, or the trigeminal nerve. The trigeminal nerve is the largest and most complex of the 12 cranial nerves. It supplies sensation to the face, mucous membrane, and other structures of the head, including the dura. It is the motor nerve for the muscles of mastication and some other smaller nerves, which I'm not going to get into, but the tensor veli palatini, digastric, but it's important to understand also the muscles of mastication. It enters the brain by a large sensory route, the portia major, and exits via a smaller route, the portia, which is the motor route, the portia minor. And it comes out of or enters the brainstem via the ventrolateral aspect of the pons at the junction of the middle cerebral and middle cerebellar peduncle. It passes laterally to join to synapse in the Gasserian or semilunar ganglion in a cave at the base of the petrous, which is called Meckel's cave. Very good. The three major branches of the trigeminal nerve are the ophthalmic, which is V1, the maxillary, which is V2, and the mandibular, which is V3. The ophthalmic and maxillary are pure sensory nerves, pure sensory fibers, whereas the mandibular nerve supplies motor as well as sensory. Adding to the complexity of the nerve is the fact that the nerve also carries autonomic fibers as well as special sensory fibers, taste. The anterior 2/3 of the tongue, the taste, is the fifth cranial nerve. The Gasserian ganglion, which is the ganglion that lives in that Meckel's cave, is identical and analogous to the dorsal root ganglion of the spinal cord, which contains the cell bodies of incoming sensory fibers from the rest of the body. And that's what the Gasserian ganglion has, the cell bodies of the incoming sensory roots. The motor fibers pass through the trigeminal ganglion without synapsing on their way to the peripheral nerves, and their cell bodies lie within the nucleus of the fifth nerve within the pons. The ophthalmic, maxillary, and mandibular division leave the skull through 3 separate foramen. The ophthalmic exits through the superior orbital fissure, or enters, I should say. The maxillary, because they're sensory fibers, the maxillary exits through the foramen rotundum, and the mandibular through the foramen ovale. And as this cartoon illustrates, the sensory distribution of the 3 divisions, as you can see, do not overlap. amongst the divisions, which is really very interesting. So when people describe the pain, they actually can almost draw a pencil or a line documenting or outlining the sensory distribution of their pain. The ophthalmic nerve, or V1, carries sensation information from the top of the scalp and mid portion and then going forward. So it's important to understand, if you split your head or scalp into anterior and posterior, the mid portion anterior is V1. If people describe pain in the back of their head, that is not trigeminal neuralgia. Maybe ophthalmic neuralgia. I mean, I'm sorry, not that, occipital neuralgia, but not trigeminal or ophthalmic portion. Mid or mid scalp and then radiates forward to the tip of the nose. It does not innervate the nares. It's also important to understand that V1 is responsible for bringing sensation from the cornea and is responsible for the afferent limb of the corneal reflex. Why is that important? Because some of the treatments we offer result in some numbness of the face. And part of that numbness can be numbness of the cornea, so you don't blink as frequently, and it can result in corneal ulcerations or injury. But I'll talk about that a little bit more when I discuss treatments. The maxillary division, or V2, innervates the lower eyelid, the nares, and the cheek. It's also important. It also innervates the upper lip, the gum, and the teeth. And then V3 is shaped like a comma and innervates the ear, the pinna, not the internal, not the canal, but the pinna, and it radiates down into the tip of the chin, but does not innervate the jaw. It does not innervate the jaw, the angle of the jaw, excuse me. And that's important to understand, again, because when people describe the pain, you want to hear the description of, it for some reason doesn't go into the angle of the jaw, but then radiates down. And it's also important to understand that V2 and V3 are the lip, the gums, and the teeth, because they often complain of dental problems, or if they feel like they have dental problems, when it's actually trigeminal neuralgia. This picture depicts the smaller peripheral branches, and I'm not going to go through the peripheral branches, all the branches, but it's important to understand that in certain types of patients with refractory trigeminal neuralgia, some of the treatments are to target these peripheral branches, to expose them, avulse them, or inject toxic agents into those to injure or damage the peripheral branches. The first description of trigeminal neuralgia can actually be inferred from writings as early as the 2nd century. Physicians such as, there are two Greek physicians in the 2nd century, Galen and his contemporary Arrhetius of Cappadocia, and they actually made their writings, they actually described these problems associated with pain and facial distortion, which is very consistent with trigeminal neuralgia. And then in the 11th century, a very well-known influential Persian physician, Abu Ali Sina, he wrote a book, and in one of his chapters, he discusses various abnormalities of the face, and one of the portions is a description is very consistent with trigeminal neuralgia. So although we have identified these early writings, the first detailed, accurate description of trigeminal neuralgia was not officially documented until the 1700s, and a French physician, Nicolas André, conceptualized in 1956, he conceptualized trigeminal neuralgia in terms of a convulsive behavior. He believed that the grimace of the pain his patients experienced suggested that trigeminal neuralgia belonged to the same spectrum of diseases as tetanus or spasms. He actually coined the phrase tic de la rue to reflect both the pain his patients described, but also the facial spasm that he witnessed his patients were experiencing. And as you all know, or I hope we know, tic de la rue has persisted. The name has persisted. And the name persisted, even though I will tell you, most of the patients I interact with don't usually have this facial tic. They sometimes do, but it's not as common as when first described, but yet the name still persists, tic de la rue. In 1773, John Fothergill, an English physician, presented his impression of trigeminal neuralgia to the Medical Society of London. He described the condition as a painful affection of the face, in which excruciating episodes come on suddenly, but last a short time, returning at irregular intervals. He also mentioned how certain actions, certain non-noxious stimulus can elicit the pain: eating, talking, tactile contact. And Fothergill discounted the concept that trigeminal neuralgia was part of this convulsive spectrum, but rather he thought it was a manifestation of some type of cancer. You know what's interesting is we still don't have an absolute definition or classification for trigeminal neuralgia. And I'll kind of express this in my subsequent slides. And they seem somewhat redundant, but I think the important point is that, again, there's no clear classification of trigeminal neuralgia. But what I will tell you, though, is that if a patient presents with paroxysmal lancinating electrical shock-like pain, it lasts for a few seconds. There are multiple attacks over a short period of time, usually asymptomatic between attacks, and they occur spontaneously, or they can be triggered by trigger factors such as cold air, brushing teeth, chewing, talking. This is considered trigeminal neuralgia or classic trigeminal neuralgia or type 1. But then there's also this entity, and if people who interact or treat patients with this type of problem, it's not uncommon for patients to present with a constant burning pain affecting a more widespread area of the face. I talked about there's no overlap between the three divisions, but when people have this sort of atypical pain, they don't describe it in such a classic, in a comma shape, in a shape that it's sort of this diffuse over the one side of the pain, over the face, excuse me. And often there's not a remission period. It's constant pain. And what's important to understand is that this type 2 or atypical facial pain, which is what I call it, atypical, it's important to distinguish between the two, because it's difficult to treat this type of pain, irrespective of the treatment, medical treatment or doing more an invasive treatment, which I can offer. And it's not uncommon for patients to describe a combination. They will often say there's an underlying constant pain with an overlapping intermittent paroxysmal electrical pain in one of the three distributions of the fifth cranial nerve, or more than one distribution. So a constant pain with this overlapping paroxysmal pain, or it may initially start off as paroxysmal pain, but then segues or progresses to this constant atypical pain, which is, again, this burning constant pain. There's also this entity known as trigeminal neuropathic facial pain. And that's essentially this pain in a certain distribution, usually V2 or V3, after trauma. And the trauma can be a dental procedure, it can be a ENT, like a sinus infection, or facial trauma. And then after the trauma is over, after the procedure is over, they have this persistent pain that can either be constant burning or paroxysmal lancinating. So as this slide represents, is what I just mentioned, that in the early courses of the disease, people have this sharp lancinating pain. They have exacerbations with longer periods of remission. And then as the pain or as the problem persists, and as months go by or years go by, it's not uncommon for patients to have this constant pain without any real periods of remission. So as I said, even now, we still don't have a strong classification. And White and Sweet offer their definition of trigeminal neuralgia, and it's the same, what we consider classic. But as you notice, they don't even talk about atypical facial pain. It's just, if you have trigeminal neuralgia, you by definition have to have this paroxysmal lancinating electrical shock-like pain that lasts a few seconds or minutes, and then you're asymptomatic between. This atypical, they don't even discuss, or they don't even describe it. A more recent publication for the guidelines for diagnosing trigeminal neuralgia is from the International Headache Society. And again, they describe two things: what we consider classic trigeminal neuralgia or symptomatic. Classic trigeminal neuralgia, not to be overly redundant, is what I keep saying: this paroxysmal lancinating pain lasts for seconds to up to 2 minutes. And it is intense, sharp, often stabbing, and it's precipitated by trigger areas or trigger points or factors. And the patient's usually entirely asymptomatic between these attacks. and the pain is stereotypical for individual patients. And what's important is it is not attributed to another disorder other than a vascular loop, which I'll talk about. So the patients don't have an underlying pathology other than a vascular loop. So symptomatic trigeminal neuralgia is identical to classic trigeminal neuralgia, except that these patients have a causative agent. They have pathology in the posterior fossa causing the symptoms. The pathology can be a tumor intrinsic to the pons or the cerebellopontine angle, an aneurysm or other types of vascular abnormalities compressing the nerve, or a demyelinating process such as multiple sclerosis. It historically was labeled the suicide disease. And this was due to a number of people threatening or actually taking their own lives because they were unable to have their pain controlled. And if anybody in the audience has dealt with these patients, you can attest, you can agree with me that these patients are not only they are in excruciating pain, which is problem enough, but they're also in very frustrated, which adds to or exacerbates their problem because they've often been misdiagnosed. They've been sent to all these subspecialists, the wrong subspecialists, to try to understand why they have this facial pain. And it's not uncommon for the patients to go to the dentist. They treat this phantom cavity, which then doesn't relieve their symptoms, which then results in root canal, which probably was never needed to be done. And then that doesn't relieve the symptoms, resulting in one tooth or multiple tooth extracted with still persistence of their pain. And then finally, someone says, maybe this is not a dental problem. Maybe we have to pursue other options. So again, unfortunately, that's not that uncommon of a story. And before modern day therapy and increased awareness, the suicide rate was quoted to be as high as 25 to 50% of those patients were affected by this disease. The patients may experience spontaneous remission, which is kind of interesting. So irrespective of the treatment that we offer, sometimes patients can have this sort of honeymoon period where they're pain-free for months to years. They think it's gone away, and then unfortunately it recurs, and then they get frustrated and they're horrible pain again. So the incidence, it's about 12 per 100,000 people. And unfortunately, it disproportionately affects us as we get older, with the majority of patients being over 50 years of age, with the average age of 63. Interesting, females are affected more often than males. And what's also interesting, and I don't have a good, nor is there a good reason, it tends to occur more often on the right side as compared to the left side, and very uncommon to be bilateral. So any of the three distributions, and you can see the likelihood of it happening in an isolated V1, V2, or V3, but more often it's in more than one distribution, with the most common being in the V2 and V3 distribution. And it can occur, but it's not that often. It occurs in all three distributions. And what is the pathology? The pathophysiology of the disease is ultimately a demyelination of the nerve at the root entry zone, most commonly from vascular compression and continuous pulsatile irritation. What is the offending artery? Shout it out. You guys all know. That's right, exactly. The superior cerebral artery is usually the offending artery. What happens is ectopic impulses are generated from the demyelinating axons. And because of the demyelation, a phaptic coupling occurs, leading to not only aberrant impulse generation, but also aberrant spreading. The phaptic crosstalk between the larger diameter, partially demyelinated A fibers, which is in the noxious fibers, or the thinly myelinated A delta and C fibers, which are the sensory fibers, results in the trigeminal neuralgia. That's what causes or results in the pain that patients are experiencing. But it also is the reason for the triggering the pain from non-nociceptive tactile stimuli or trigger points. The irritation and subsequent demyelination can result from other pathologies, as I just mentioned. And the International Headache Society considers that symptomatic trigeminal neuralgia if the irritation, demyelination, and a phaptic crosstalk results from tumors intrinsic to the pons, cerebellopontine angle, aneurysm, or demyelinating process such as MS. 2% of patients with MS experience trigeminal neuralgia. And if it is bilateral trigeminal neuralgia, 18% of the time the patients usually have or 18% of the time, patients had multiple sclerosis. So if it's bilateral, more often patients are afflicted with multiple sclerosis. The differential diagnosis can be and should be able to be vetted based on a good history and a good physical. But herpes zoster, a well-known cause, as we all know, is caused by the varicella zoster virus. And this pain that people describe is constant, not paroxysmal, and often in the V1 distribution. And as I showed you in my previous slide, which is uncommon, but the sine qua non of herpes zoster is the crusting or the vesicles that occur just as the pain is disappearing. So usually occurs after the pain, but is present, thus can differentiate between trigeminal neuralgia. And then a negative sequelae of the herpes zoster is post-herpetic pain. So the virus is lying dormant, and yet the pain is persistent. And usually, again, it's a constant burning pain in the V1 distribution. And it's important to ask the patients, did they have crusting or vesicles prior to this now post-herpetic pain? Glossopharyngeal neuralgia is, in terms of the description of the pain, paroxysmal, lancinating, asymptomatic between is identical to trigeminal pain, except for the location. Glossopharyngeal, it's the ninth cranial nerve. The pain is in the back of the tongue, back of the throat, and in the external auditory canal, not the pinna. In the canal, back of the throat, and back of the tongue. And the trigger tends to be swallowing. And we say is in trigeminal neuralgia, patients can't chew. In glossopharyngeal neuralgia, patients can't swallow. And then there's some other, yes, you always, although patients are misdiagnosed, but you do have to rule out an underlying dental problem, TMJ, certain vascular problems, giant cell arteritis, and you can read this slide as well as I can read it to you. But again, what is important is a good history and a good physical. And with pain, you have to rule out an underlying problem, tumors in the posterior fossa, aneurysms, demyelinating process. So that segues into my next slide. So how do you evaluate these patients? Very important is an accurate description. You need to get a description of the pain, and you need to ask them, is it constant? Is it burning? Is it a lancinating, electrical shock? Do they have triggers? The duration of the pain? Are they on medicines? Obviously very important. Then you do need to ask about their herpetic vessels. Is it an active herpes virus or is it post-herpetic pain? And then a good exam. A good exam entails a sensory assessment. You need to assess, all the cranial nerves and the motor function, but we're kind of focusing on the fifth nerve. And so you need to assess sensation on the three distributions. Corneal reflex, it's important to get a baseline corneal reflex, certainly before you start discussing treatments. And as I said, the portia minor is the muscles of mastication. So the master, you bite down, and the pterygoid function open the mouth, and the mouth deviates towards the injured fifth nerve, if indeed there is problems with the fifth nerve. Now, in terms of working the patients up, the first thing I do is obviously get a good history and a good physical, but then I always obtain an MRI. Even if the patient has classic type 1 paroxysmal trigeminal neuralgia, I always obtain an MRI with and without contrast and an MRA. Why am I obtaining these studies? I'm doing MRI with and without an MRA because I'm looking for a demyelinating process, an MS plaque. I'm looking for tumors intrinsic to this brain stem or in the cerebellopontine angle, or I'm looking for some type of vascular abnormality, an aneurysm that may be causing the problem. I don't get an MRI with and without to look for a vascular loop, but what I do is now, and part of a very important part of my imaging sequence is a FIESTA study. A FIESTA study, excuse me, stands for Fast Imaging Employing Steady State Acquisition. And what it does is it allows us to obtain high quality detailed images of soft tissue, particularly those with high water content. It allows us to visualize structures that may be difficult to see with other MRI sequences, specifically cranial nerves in the posterior fossa and blood vessels that may be irritating the nerve. I will tell you that I looked at this FIESTA study. This is what is depicted as the FIESTA study on the screen. And before I even saw the patient, I knew there was left-sided pain. This is the fifth nerve emanating out or coming into the ventrolateral aspect of the pons, and it's sort of grayer than a much darker black structure that is juxtaposed to the nerve at the root entry zone, and it's, you can tell it's somewhat ventral to the nerve. This woman indeed had left-sided facial pain, and this, as I said, this Fiesta study very clearly sees the artery, or depicts the artery, I should say, that's irritating the nerve. But the MRI, as I mentioned, I obtained the MRI with and without to see if there's any underlying structural problem. This gal is referred to us. She initially presented with paroxysmal pain in the face on the right side, and you can see the cerebellopontine angle tumor. So what was the goal of treatment? The goal of treatment really was to treat the tumor. We also included the nerve within the radiation dose. Unfortunately, the patient did not get relief of her symptoms. We started with a therapy, in terms of which I'll talk about the various therapy, but I had to offer a different type of therapy, which I will talk about. But it's important that we identified the CP angle tumor, and it manifested as pain in the face. So anti-epileptic medicine is indeed the first line of treatment. It's the cornerstone for treatment. And even if it's related to a symptomatic, even if there's an underlying problem like a tumor, an aneurysm, if you treat the tumor or the aneurysm and the patient still has persistent pain, then again, you start off with anti-epileptic medicines. And this is not overly new, that you start off with a low dose and then you titrate to relieve the symptoms, or you titrate up until the patient has side effects. And it's not uncommon that the patients initially are quite responsive to a specific medicine, but then they become unresponsive. So you have to either increase the dose or you rotate different medicines. And Tegretol and Trileptal, but Tegretol is still the gold standard. And not only is it therapeutic, many docs say that it's not only it's therapeutic, but it's also diagnostic, meaning if the patient's not responding to Tegretol, is it truly trigeminal neuralgia? And again, you start low and titrate up. And usually, although it says usually it's 600 to 800 milligrams a day. You try not to exceed 1,200 milligrams because the patients have side effects they can't tolerate. So again, Tegretol and Trileptal are usually our first line of therapy. Dilantin, if the patients are in a persistent severe pain, they can't tolerate any PO agents. Sometimes I have to admit them through the ER, and then I'll start them on an IV Dilantin, and that to help relieve the pain. And then we start with PO agents. My second line therapy is gabapentin, Neurontin, and then Lyrica, but others may use baclofen. Tricyclic antidepressants I tend not to use other than for very atypical features. It tends to be more therapeutic, more effective for atypical facial pain. This is just a nice table that just you can easily follow, and it demonstrates the first line of therapy. Again, Tegretol, carbamazepam or oxycarbamazepam, Tegretol or Trileptal, and then you start off low and start to titrate up. Usually the therapeutic dose is 600 to 800 milligrams. You can divide it between 2 to 3 times a day. And then you try not to exceed 1,200 milligrams just because of the side effects. Patients usually can't tolerate too high a dose. And then my second line of therapy tends to be gabapentin as opposed to Lyrica, but others often try baclofen. It can be quite effective. And then you always have to kind of keep in mind, and you have to talk to the patients about the side effects. Almost every medicine that we give has central nervous system or side effects that result in cognitive changes. Either they feel like they're drunk all the time, their head's in the cloud, they just don't feel right, they're overly sedated. Those are some of the side effects, and that's often, again, why we start low and then titrate up so that the patients can sort of tolerate, or they can become accustomed to this odd feeling. It's very rare, but one of the more severe side effects of the medicine of carbamazepam is Stevens-Johnson syndrome. And then also I do get around a month after, I do get lab work, including just to assess white blood cell count as well as sodium levels. And then what is the next step? So the data dictates that up to 25 to 50% of patients become unresponsive, where they can't tolerate the medicine because they don't like the side effects. But in my practice, it's close to 100%, because the reason they're coming to see me is because they no longer can tolerate the medicines they're on. And what I don't do is I don't add another medicine. If the patients, again, usually they're on a host of medicines, but if they haven't been on one specific medicine, I don't go, you haven't been on gabapentin. You've been on 5 other medicines, but you haven't on, let's try gabapentin. I don't do that, because the likelihood of them improving with a medicine that has not offered them any relief is very unlikely. So then I talk to them about treatment options, and I go into great detail about the treatment options. In my mind, I divide the treatment options into non-destructive and destructive, and I'll explain what that means. But also you can divide it into sort of maximally invasive or minimally invasive. The maximally invasive is brain surgery or microvascular decompression, and then the destructive lesions, which means the purpose of the goal of the treatment is to actually injure the nerve. That's through rhizotomies, stereotactic radiosurgery, or peripheral ablative procedures. I don't do the peripheral procedures. That tends to be OMFS or pain doctors with peripheral injections. So let's talk about the surgery. In 1891, Sir Victor Horsley proposed the first open surgical procedure for trigeminal neuralgia. That involves sectioning of the preganglionic rootlets of the nerve. In 1925, Walter Dandy advocated the partial section of the nerve in the posterior cranial fossa, and it's actually during the procedure, he observed the nerve was being compressed by some type of vascular loop. And in 1932, Dandy theorized that the trigeminal neuralgia was caused by a blood vessel compression at the root. With the advent of the operative microscope in 1967, Janetta, again, with the intraoperative assessment of the nerve, he said, yeah, there is indeed a blood vessel there, and rather sectioning the nerve, maybe we should displace the artery off the nerve. And that was sort of the birth of the microvascular decompression, or the Janetta procedure. Janetta pioneered the procedure, in which he moved the offending blood vessel, excuse me, and placed a sponge to prevent the vessel from returning to the native position. Janetta's procedure, now known as microvascular decompression, was somewhat controversial at the time. But then, as time progressed and using the microscope, other surgeons again experienced the same thing with this vessel compression. They modified the surgical procedure, and now it's a well-accepted, as we all know, surgical procedure. Microvascular decompression is regarded by many as one of the most important modern breakthroughs in the treatment of neurologic diseases. I place the patient in a lateral park bench position. Some neurosurgeons place the patient in a supine position with a bump and their head turned. I don't recommend this because there is a great chance of kinking the jugular vein, resulting in reduced venous outflow, and this often is resulting in cerebellar swelling and posterior fossa swelling. So I place the patient in a lateral park bench position, which is just what you see here on the screen. My incision is just a nice linear incision behind the ear. And then my bone opening is about the size of a silver dollar. And I want to make sure I see the transverse and sigmoid sinus, because I'm going to be working right up in this corner. And this movie is a right retrosig, which is the type of craniotomy, is a retrosigmoid craniotomy, because it's behind lateral to the sigmoid sinus. And then what I'm doing there is I'm just incising the petrous vein, excuse me, the petrosal vein, excuse me. And now I ligate inside the petrosal vein, and now I see the largest of the 12th cranial nerves, the 5th nerve, emanating out of or going into the pons, going lateral into the Gasserian ganglion. And here you see, this movie is wonderful in that you see this artery that's dorsal to the root, compressing the nerve, pulsating the nerve, on the nerve, resulting in the irritation. And now this white structure is this white Teflon pledget or pillow that I'm putting between the nerve and the artery, so I decompress the nerve. Nerve, artery, this white Teflon pillow. This is a great view. You see, I think this was the MRI showed you the Fiesta study. This was the artery, supracerebral artery pressing on the nerve. It's just a great image. They clearly see the offending artery. The size and shape of the Teflon sponge should not be trivialized. There was a study published in the Journal of Stereotactic and Functional Neurosurgery that reviewed 685 patients who underwent microvascular decompression for hemifacial spasm. Now, hemifacial spasm is a spasming and problem with the seventh cranial nerve, but the pathology is identical in that there is an artery that's compressing the nerve, causing irritation, which results in the spasming of the face. And the surgery, the microvascular decompression, is identical. So you can use the information from this study and pertain it to the microvascular decompression for the fifth nerve. And the bottom line is 31 patients needed to be reoperated after the initial surgery. They needed to be reoperated on within a week because of unsatisfactory outcome from the initial surgery. And all patients were symptom-free after the second surgery. And the failure of the surgery was attributed to the Teflon insert. Improper placement, not suitable shape, and not suitable size. So the Teflon insert is used to keep the offending artery away from the nerve rather than isolate the nerve. What I mean by that is it's not, and I've seen this with sort of inexperienced neurosurgeons who are treating, they just kind of bathe the nerve in a sponge and they just kind of throw a whole lot of sponge in there. And you don't want to do that. All you want is enough of the sponge, which is this white structure here, to isolate the nerve, or I'm sorry, not isolate, to displace the artery away from the nerve, not isolate the nerve. So the ideal sponge should be just small enough to produce a neurovascular separation, but obviously large enough to create that separation along the course of the nerve, most specifically at the root entry zone. That's what's important, is look at the root entry zone. This is another wonderful picture of the artery compressing the nerve. And then, as you can see, just a lovely displacement. I've displaced it all the way back to the root entry zone, and there's my hole that I'm going to put the Teflon pledget in. So what are the pros and the cons? So it's important that the microvascular decompression is really the only it's the non-destructive procedure. What I mean by that is the goal is to not injure the nerve, but rather displace the artery away from the nerve. So it's really also the only treatment that addresses the problem, that is the artery that's pressing on the nerve. Because it's not destructive, meaning because the goal is not to injure the nerve, it has the lowest risk of any kind of sensory problems associated with destructive. So which I'll go through in a little bit greater detail. The dysesthesias or anesthesia dolorosa is very uncommon in this procedure. And as I said, it's the only procedure that really addresses the underlying problem. And longevity, that's very important. It lasts the longest. So it's important when describing these treatments to the patient. Yes, it's the most invasive, but as you can see from this slide, and what's important to understand is all the treatments offer a greater than 90% success rate initially. So they're all very successful initially in paroxysmal or the classic trigeminal neuralgia. But as time progresses, the less invasive procedures, the recurrence of pain tends to occur, and long-term effects of the less invasive procedures we really don't even talk about because the recurrence rate's higher beyond 4 years. But this is not similar to a microvascular decompression where the procedure lasts anywhere from 10 to 15 years. And you can see at 10 years out, still the majority of patients are pain-free. And again, the injury to the nerve is minimal. So the chance of facial dysesthesias or numbness is very low. This is for glycerol-rhizotomy, 60% facial numbness, as opposed to 2% in the MVD procedure. But there are cons. And the obvious is that it is brain surgery. So it's not suitable for those patients with medical comorbidities or at a certain age that they can't tolerate the open procedure, the brain surgery, and the anesthesia. This is just the risk we talk about with our patients. Mortality, usually it's more associated with anesthesia, but then there is always a risk in terms of post-op hemorrhages, the risk of mortality. Meningitis, cranial nerve dysfunction, we do monitor the rest of the cranial nerves, so the chance of injury to the rest of the cranial nerves are low, but there is a chance of injury to the with vestibular problems or deafness, facial weakness, etc. But usually, again, it's low risk because we monitor. The other procedures that I do offer that I discuss are far less invasive, but they are destructive procedures. As I keep saying, they're destructive and non-destructive, but they are the goal of these non-invasive or less invasive procedures is to injure the nerve. And because of the injury of the nerve, the goal is to injure the more friable, the fragile nociceptive fibers and maintain the more robust sensory fibers. But even though that is the goal, there is always the chance, there is a higher chance of injuring the sensory fibers. Thus, the patients can get the facial numbness. And with facial numbness, they can get problems associated with that. As I mentioned already, V1, the afferent limb of the reflex, of the corneal reflex. Thus, if you don't blink, you can get irritation, ulcerations of the cornea called neuroparalytic keratitis, and it can result in visual loss in the same eye. You can also get this problem known, which is it's a very difficult problem to treat, is anesthesia dolorosa, which literally means painful numbness. The patient has numbness in the face, but still has persistent pain, and it's considered as a deafferented pain syndrome. And it's thought that the pain is now focused or centered in the thalamus, and again, very difficult to treat. I'll kind of go a little bit faster. I apologize. Stereotactic radiosurgery can be administered under a number of ways. You can use a cobalt source administering gamma rays to the nerve, or now we can often photon beams. And what I tend to use is the CyberKnife, which combines image guidance and robotics to deliver radiation to a precise area of the nerve. We tend to, the target is a little bit displaced off the root entry zone. The concept of stereotactic radiosurgery was first introduced in 1951 by Lars Lexell, and he treated trigeminal neuralgia, which is really kind of interesting, with a prototype guidance device linked to a dental X-ray machine. And he used, essentially what he did was stereotactic radiation ganglionectomy, and it was quite effective. The advantage of the stereotactic radiosurgery is it's the least invasive of all the procedures we offer. A CyberKnife, that we don't even need a head frame, so it's just a mask that's made for you. So it's ideal for patients who are not, who obviously do not want anything invasive done to them, or patients who are poor candidates for general anesthesia with medical comorbidities, or patients who are on blood thinners. And again, it's very successful. It's very, the success rate in terms of initial pain relief is very high. But there are downsides. There's always pros and cons to everything we do. And the latency period, the time it takes for the radiation to do pathologic changes to the nerve to occur, which results in pain relief, takes about 6 weeks to 3 months. So it doesn't work right away. 6 weeks to 3 months. This is an older slide. And I used to show this. There was always a concern about radiation to the brainstem. Don't recommend it for younger people. But the truth is, we've been doing this for over 2 decades with radiation, I should say. And because we moved the target a little bit away from the root entry zone, the brainstem sees the radiation that the brainstem sees is well within the accepted range. So we've not seen any long-term problems associated with radiation to the brainstem, nor have we seen any really problems with young people with the radiation to that area. So I really, in terms of the downsides, I kind of focus on the latency period and the fact that, as I mentioned previously, the long-term effects. First of all, only in radiation, really only 65% are pain-free. The rest have, as I said, it's successful in reducing the pain, but only 65% are pain-free. And as time progresses, the pain recurs. And after 4 years, theoretically, the pain has recurred. And so it's not ideal for a long-term treatment. Doesn't have great longevity. And as I mentioned, the goal of the destructive lesions, radiation treatment, or the the percutaneous radiotomy is to injure the more friable nociceptive fibers, preserving the more robust touch fibers. And this can be done by, in the percutaneous procedures, by advancing a needle into the Gasserian ganglion, administering heat, resulting in thermal injury to the Gasserian ganglion, inflating a balloon in Meckel's cave, resulting in mechanical trauma to the Gasserian ganglion, or inject alcohol into the Meckel's cave, resulting in a chemical-induced injury to the Gasserian ganglion. What is that? What are the advantages? Well, it's minimally invasive. It's not brain surgery. So thus, it's ideal for patients who are poor risk for anesthesia, for general anesthesia, excuse me. It's great for elderly or patients who have limited life expectancy. Not that as we get older, but you understand what I'm trying to say. It's ideal for patients who have problems in the posterior fossa that we can't treat, unresectable tumors, and tumors that are intrinsic to the brainstem, or multiple sclerosis, a demyelinating process. Glycerrhizotomy was developed as a chance finding in 1981. Hackinson and Lexell were working on pioneering their use of stereotactic radiosurgery. I mentioned that Lexell invented the stereotactic radiosurgery, and they had to work on trying to identify so they could target the Gasserian ganglion. They used glycerol as a carrier to inject tantalum dust into the trigeminal cistern to localize the nerve for radiosurgery, to target that nerve for radiosurgery. And what they discovered after the injection of the medium alone, after they injected the alcohol, the patients were pain-free. Thus, the birth of a glycerrhizotomy. And really, the technique hasn't changed that much over the years. I tend to use advantages over the other procedures. One is the patients do not need to be awake for the procedure, and it's not a comfortable procedure. You're advancing a needle through the cheek into the foraminal valley, so the patients don't need to be awake, and it can be anyway. So the technique, and it's based on anatomic rather than physiologic landmark. The precise anatomic localization of the Meckel's cave can be done through a cysternogram, which I do. I inject contrast into the Meckel's cave to identify it. And I find, and as well as the literature supports the fact that glycerrhizotomy tends to cause less facial sensory problems as compared to radiofrequency or rhizotomy or balloon compression. So there's lower chance of anesthesia dolorosa or neuroparalytic keratitis. And also, the glycerrhizotomy tends to be the treatment of choice for patients with multiple sclerosis. There have been papers advocating a microvascular decompression or a surgical procedure for even young people with MS. I don't agree with that. I think that's not the right thing to do, because there's usually not a vessel that's compressing the nerve. It's an MS plaque. So I will offer the percutaneous glycerrhizotomy. And as I said, in all these treatments, the initial success rate, especially for the classic trigeminal neuralgia, is very high, greater than 90%. So I position the patients in the upright, somewhat flexed, neck flexed, as you see this cartoon picture. And in this flexed position, upright position, Meckel's cave is parallel to the floor, which prevents the glycerol from pouring out of Meckel's cave immediately after the injection. And this can create somewhat of a anesthetic issue, because ideally what I want the patients is sedated enough that they're comfortable, but not too sedated that they slump over and not able to maintain that fixed flex position. And I keep the patients in this upright flex position for 6 hours. Excuse me. So the Gasserian ganglion is bathed in the glycerol, maximizing its effectiveness. I do the procedure under C-arm or fluoroscopic guidance, and I use a 5-inch 22-gauge spinal needle. My insertion site is roughly 2.5 to 3 centimeters lateral to the oral commissure. And I advance my needle at a trajectory so that it's in line with the middle of the pupil. middle of the pupil, and theoretically, it would intersect a line that is 3 centimeters anterior to the external auditory canal, intersecting the pupil. But I try to advance my needle in line with the pupil. And on lateral view, and usually I do lateral X-ray. I advance my needle so that I am roughly 1 centimeter inferior and posterior to the sella turcica, to the floor of the sella. See the floor of the sella? This is my needle that I'm inserting. And it advances through foramen ovale and going into Meckel's cave. My landing point is where you can see this really nicely here, the petrous bone and the clivus, where the junction of the petrous bone and the clivus, or where they intersect. And that's my landing zone. So inferior, about 1 centimeter below or posterior inferior to the sella turcica, my landing zone, petrous clival junction. And then on all my cases, I do a cisternogram. I inject contrast to so that I can visualize Meckel's cave. In the virgin cases, when I remove the stylet of the spinal needle, I often get spinal fluid, but that doesn't always occur in repeat cases. And you can see this is a patient that underwent a suboccipital microvascular decompression that did not work well. So I did the glycerol. I'm going to speed a little bit faster. I have 7 minutes. The bottom line is, as I mentioned multiple times, ideal for patients who are poor risk for general anesthesia, older patients who have an underlying pathology we can't treat, such as MS yeah. And then again, the immediate relief is excellent. The downside, as I said, it's a destructive process. Thus, there is abnormal sensation in the face resulting in possible anesthesia dolorosa or neuroparalytic keratitis. And the long-term effects, yes, the initial success, very high, but then the recurrence after years is higher. And after 4 years, we really don't talk about long-term effectiveness because the recurrence rate in terms of pain is very high. The same process can be done with thermal injury. It's called a radiofrequency rhizotomy. And again, the goal, same process, same concept. The goal is to injure the more friable nociceptive fibers, but preserving the more robust sensory fibers. It was first introduced in 1931, then modified by Sweet in 1970. And the patients are awake for this. They are sedated for the insertion of the needle, but then they're awake, so you can stimulate the Gasserian ganglion. The patient says, that's where the pain is, and then you start administering heat. And there is a chance of injuring surrounding structures, by advancing the needle too far, but also the expansion of thermal energy to neighboring structures, such as the optic, can result in injuries such as blindness. Or you can go through the infra or supraorbital fissure, resulting in blindness. You can also inflate a balloon, and we talked about that, resulting in mechanical trauma. And then there's the peripheral procedures. So attacking and targeting the smaller peripheral nerves is also an option. You can essentially freeze the nerve with a cryoprobe, or you can inject toxic agents, alcohol, not so much streptomycin. Many people are using now Botox, injecting peripherally. Or you can expose the nerves. This is not done by neurosurgery. I've not done this, usually by OMFS, and you expose the nerves, and then you actually ligate the nerves or avulse the nerves. Also effective. And then this slide just kind of goes through just a basic workup. But what's important is I always obtain MRIs and Fiesta study, as I mentioned, and then I will then indeed start with medical management. If it's symptomatic, meaning if there's an underlying pathology, then I'll certainly treat the underlying pathology. If that does not result in relief of pain, then I start my medical therapy, as we talked about. Oxycarbamazepam, Tegretol, Trileptal are the first-line therapy. Then many people do go to baclofen. I usually go to gabapentin. And then if that doesn't work, then proceed with more invasive treatment. So it's always a multi-tiered approach, always. I talk about the different medicines. We talk about the pluses and minuses, and then I discuss the treatments. And as I said, all treatments are initially highly effective in alleviating or relieving some, if not all, the symptoms. But it's important to discuss longevity with these patients. And it's important to not just treat everybody the same. as I talk about with all the treatments we offer, it's important to create an algorithm that's ideal for the patient, not what's best for you. So you discuss medical comorbidities, not just chronologic age, but medical age, because I'm doing microvascular decompressions in older patients if they're doing well, if there's no significant medical comorbidities. Some patients, young patients, don't want any surgical treatment, so I offer a needle or stereotactic radiosurgery. And again, you need to discuss all options and the pluses and minuses so the patients make an appropriate conformed consent. And that's it. Go birds. Do you have any questions?
For Liebman, there is one question in the Q&A. Do you see that?
I don't.
I can read it to you if you'd like.
Yeah, sure.
Dr. Sullivan asks, is it possible for a patient to have multiple facial neuralgias? I have a patient with occipital neuralgia that improved with occipital nerve blocks. Another facial pain that most likely resolved with baclofen, but now has severe throat pain without an obvious cause that I believe is glossopharyngeal neuralgia. It may be Tegretol, but should I be thinking about a demyelinating disease?
Well, as I said, in terms of my evaluation or workup, I would get imaging and MRI with about the contrast. I would even do MRA and a Fiesta study to see if there is an underlying problem associated with why the patient has multiple neuralgias. Do they have a demyelinating process? So yes, it's very appropriate to get imaging such as an MRI to make sure there is no underlying problem. But I will tell you that I have had patients, and it's a great question because I have had patients who have glossopharyngeal or trigeminal neuralgia with occipital neuralgia. And so I have had that sort of this heightened or increased inflammatory process that results in pain in the different distributions. And that's kind of why I talked about I'm going off topic, but that's why it's important to get a good history of physical because again, pain that is sort of in the back of the head is not trigeminal, it's more occipital. So, but the answer is yes, and I would work up that patient to see if there is an underlying problem. Yes. Any other questions? Okay. I hope you liked it. It's tough to get feedback when it's virtual, but thank you.